Good evening, everyone. This evening is a celebration, and I would like to introduce my friend and colleague, Hesham Saleh, who has recently received a great honor from Imperial College, which to my mind is well-deserved and probably overdue. And he has been made Professor of Practice in Rhinology at Imperial. Now, Hesham I've known for many years. We were trainees together, and unfortunately we became colleagues together, and we worked together for nearly 20 years as consultants. And he is a unique individual for those that know him. And you soon realize he is someone who would have risen to the top in any endeavor, in any field, because he is exceptional. He's an exceptional surgeon, and he has exceptional people skills. He calms the situation, and he's loved by all. A little bit of background: he is actually a first-generation immigrant. He arrived in the UK after qualifying in medicine, doing his house jobs and his military service in Egypt. And he is now one of the foremost rhinologists in the world. And as I've said, he's one of the most skillful surgeons I've ever seen work. He is invited to lecture around the world. He never loses his enthusiasm to teach, and he's a leader in research in rhinology. Some of his honors, and there are too many to mention, but I'll run through just a few. He has been president, or is president of the European Academy of Facial Plastic Surgery. He is president of the British Society of Facial Plastic Surgery, or was in 2017. He was president of the section of laryngology and rhinology at the Royal Society of Medicine 2015. So this evening, he's going to give a presentation which is to take us on his voyage through the nose. Now, before he starts, just a couple of points to make. If you have any questions, please submit them on the Q&A slide on the side of your presentation where you're seeing the presentation. If you do not want your name to appear, please bear in mind the event is being recorded, so omit your name. If there are any questions that you do like and would like to come to the top of the list for being posed to Professor Saleh, then please give those a thumbs up and they will be pushed towards the top. So now I would like to invite Professor Saleh to give his presentation. Thank you, Hesham.
Thank you so much, Guri, for this amazing presentation. I hope I can live up to this. I really appreciate this. Very nice of you to say this all nice things about me. I'm very happy to be here today as well. I want to say this is an inaugural lecture. It's a big thing. It's a nice thing. I'm going to really enjoy it with you. That's why I've decided to talk about a voyage through the nose, my journey through the nose since I started as a trainee and consultant in rhinology. When I was looking at inaugural lecture in the Imperial, I looked at the first one, which was 22nd of March, 1955, a long time ago, by Professor Alfred Uberhold on chemical engineering, which was entitled Thermodynamics in the World Today. Looking further, I found another interesting one. Here we go. Lecture on field cancer research by Joe Biden, October 18.
It's an honor to be here before so many distinguished people. My distinguished guests, my fellow Americans.
Not to be confused with this one. Only 2 years later. Who knows what happens after inaugural lectures in the field? So I'm going to talk about my voyage through the nose and 3 things I'm going to talk about in my lecture. I'll start with a brief recent history, just a recent history of understanding of sinus disease. Then I'll talk about my voyage through working into the nose and outside the nose. And then just a brief discussion about future, what I think the future will hold for us in rhinology. So the brief history starts with surgery, destructive surgery, we call it sometimes, of the nose. We didn't understand, or people before us didn't understand the natural mucociliary clearance of the sinuses. And when they had people with infective sinuses like this, they tended to open holes in the bottom, inferior antrostomies like this, understanding that gravity would probably let these secretions come out and no infection. But you could see secretions, infections stayed there despite these holes. If this didn't work, they did something even bigger, canine fossa approach, caudal approach, when they made a hole and removed all the mucosa. That created scarring, osteoarthritis with thickening of bones, and the patient was still not healed. With nasal polyps, they pulled them out, sometimes with a snare like this one, or just with forceps. without understanding of the mechanism of the pathophysiology of nasal polyps and the treatment that should be associated with this. And that's why they recurred so many times. And you could hear about people who've had surgery 15, 20 times for nasal polyps in the past. People ended up with empty nose syndrome, as we call it now, from multiple surgeries, with removal of everything. They ended up with that big cavity inside the nose. Everything is gone, and dryness and feeling of blocking continuous and pain as well. So it did not work and even make things worse. Luckily, we had Harold Hopkins. He was a lecturer in optics at Imperial College when he was doing research on optics, and invented the Hopkins rod, or the rod lens, which created the current endoscope that changed the world of sinus surgery and other surgeries, creating keyhole surgery. He later on moved from Imperial, became professor of optics, the first of its kind in Reading University. He invented that endoscope, and that was used by Professor Walt Klinger in Graz, Austria, to study the mucociliary clearance, initially in sheep, here putting ink. You can see and follow the ink coming out, and realize that the natural mucociliary clearance always comes up against gravity toward these natural ostia, and from here as well. His student at the time, Hans Sternberger, was with him following all these steps, and he is the one who popularized, because of his nature, his way of teaching, and his kindness. He was such a nice man, went all over the world teaching Klinger techniques. Klinger and Heinz realized that that area is the key for sinus problem, and obstruction here is the reason that you could get accumulation of infections and chronic sinusitis and so on. And when you want to target the sinuses, you want to target this area here, not this area here. So functional endoscopic sinus surgery was born, or endoscopic sinus surgery, and this is the same from Heinz Sternberger at the time. The radical surgery of the paranasal sinuses and maxillary sinus fenestration in the inferior major disappeared practically overnight. We wish, though, it didn't practically overnight disappear, because obviously people who were trained in the other kind of surgery continued for a while, but gradually disappeared. And I would say now, probably, that old-fashioned type of surgery is not done anymore. I was there early on, just not that time, but just behind that. I was beginning in my training. So my voyage goes into that time when endoscopic sinus surgery was there. I decided to ENT because I like it. ENT is a nice specialty, especially rhinology. I'm biased. I love rhinologists. I would say that I wanted to do rhinology because it was expanding. The new specialty was coming out, and I liked actually doing it. I have to talk about my teachers, my mentors. I could say I'm a second, maybe just 1.5 generation rhinologist. First time I saw endoscopic sinus surgery done the way that Mr. Klinger and Sternberger described it by Nick Jones in Nottingham. I was just a junior doctor, so I wasn't allowed to do anything. I just watched it, and I just fell in love with it. Later on, I learned more from Paul White in Dundee. And then my mentors, Valerie Lund in Royal National ENT, and Ian McCall, who were the leaders of rhinology in the UK, taught me in my final 2 years of training. And from then, I never looked back. Here they are, London Mackay, both of them, my mentors, only a few years ago. And I'm very glad that after Ian retired from Charing Cross, I just continued there. So I started at Charing Cross just ended 2001, 2002, and later on joined the Royal Brompton Hospital. And Ian Mackay has already established a tertiary referral unit with sinus surgery and Septuarinoplasty. We're having new system for endoscopic surgery and so on. And everything was happening. And people just start to understand Mr. Klinger's concept of mucociliary clearance. And endoscopic sinus surgery started to become a standard, but it was not standard yet. So I was still in that exciting time when people were still learning and improving, apart from our leaders, of course. We're the second generation there. So when I started, I decided I want to push more for other things. So I appointed an allergy nurse. We decided to start routine allergy testing, but more importantly as well, I always found that nobody was doing smell testing routinely. So we started doing smell testing because olfaction is an essential part of the whole of a sense in the nose. So we started testing that. And I introduced the image-guided system in Charing Cross Hospital in 2002. Just think about the sense of smell, because it's becoming a big thing because of COVID now. And now people realize how important sense of smell is. Clearly, I'm showing somebody who's sniffing wine because that's his job as a wine taster. Some jobs are great, but some jobs are not as great. So you have to have a good sense of smell for this one too, but I wouldn't fancy doing it though. But obviously the sense of smell is very important. So we started using the standard test at the time, University of Pennsylvania smell identification test. Tested design in the States, was validated for thousands of patients. It was a really good test. We discovered early on that there's something not quite right about testing people in the UK comparing to the Americans, because some of these smells were very unfamiliar. And we found, interestingly, the commonest one that people didn't recognize was cheddar cheese. Cheddar cheese is obviously an English thing, but one in the States is very different. So people make mistakes in this all the time. Dill pickle, turpentine, musk, root beer, lemon, also didn't recognize them. These were the ones that you have to choose to actually be accurate in the test. And these other names were written there in a multiple choice that people also didn't recognize. So we did that study, which we published later on, 2 years later, but we worked with a company with the producers of the smell test, and that ended up producing the British identification or smell identification test that we currently use, which we use routinely. Image guided this system probably has changed my practice so much in endoscopic sinus surgery. It was the first to have in the UK in an ENT department at the time, very expensive, but we managed with the help of the MKI to get it in Charing Cross. And that really helped me a lot because also that new instrumentation and the camera system was started to appear, like these angle instruments that will go all the cavities of the sinuses, and gave us the idea that we can also explore other areas within the sinus further from the sinuses themselves. One of the early studies we did because of sinus surgery with my clever SHO at the time, resident Nurai, is to measure the antrostomy, see how much they narrow with a special software to try to improve our techniques in surgery. And I also embraced a lot of the new techniques when things came up. We tried them and we tested them, we published them, like balloon sinuplasty, for example, at the time, early on when it first appeared, and something like the low pressure dilation of the sinus ostia. And more recently, things like steroid-eluting stents, which seem to be very effective, very useful in many of the severe sinus conditions like nasal polyps and so on. And we published on them recently as well. But when you do rhinology, you realize you're not alone. It's really great. That's why I like it, because you actually work with other people. So you realize you're going to work with allergists and respiratory physicians, neurosurgeons, ophthalmologists, neurologists, plastic surgeons, xylofacial surgeons, dermatologists, and so on, which is a great part of it. And I was very lucky from the beginning to go and start working with Steve Durham in the Brompton Hospital. So I joined Steve in the Brompton later on, a couple of years later, to the nose clinic was already established by Ian Mackay. And here's Steve, me, really maybe 17 to 16 years ago. You can see I had a lot of hair. Steve had a lot of hair. He still has a lot of hair. So I lost my hair. I changed, Steve hasn't. So this is the nose clinic that we still run in the Brompton. And the nose clinic is a great thing because you learn there that the nose is the part of the lung which is accessible to the finger. You really learn that the disease is common. There's a lot of areas of common inflammatory processes and so on. And you treat the nose, you have to consider the chest and vice versa. You do learn a lot there. Conditions we see there, they teach us a lot. And I've been very lucky working there, learning from physicians and allergists, but also involved in research with them and publishing in medical textbooks and allergy books and so on. So the things that we see commonly in the nose clinic, things like rhinitis, whether allergic or non-allergic, Santostride, the patient with severe polyps, aspirin allergy, and asthma. With this patient, for example, with expansion of the nasal bones from the severe polyps. Patient with cystic fibrosis, a large cohort of patients with cystic fibrosis. You can see the polyps here and the CT scan, and all these pseudomonas infections very commonly affecting these patients. This particular patient had renal transplant, lung transplant twice, which is now allows these patients to survive beyond 50 and 60 years old. Another condition is primary ciliary candidemia, lack of function of the cilia, with dependent secretion in the nose. Some of them have these dextrocardia. You see that polypoid changes and these thick secretions that attract infection and cause lots of problems to these patients. So we see these patients regularly, and it's something you don't see in normal clinics. Another large group or large cohort of patients would see a sarcoidosis. I'm just showing the severe cases here with intranasal sarcoid nodules here on the left nostril, but also that lupus permeable change in the skin, and something even worse with large nodules on the skin of the nose with crusting and scarring inside the nose. And finally, granulomas, polyangiitis with GPA. We see them in this clinic as well, and we treat them jointly with physicians. And that's how we learn about managing these conditions. Some other very, very rare things that we see, like Church-Strauss syndrome, Young syndrome, and yellow nail syndrome, which was described in the Brompton, a small handful number of patients that we see every now and then and treat. The nose clinic is great because I learned my other side of thing, being a physician as well as being a surgeon. And you realize, though, you just don't want to operate on everything. And the mainstay of these difficult conditions is medical treatment. Early on, the chest physicians started from their studies using macrolide antibiotics that later appeared in the sinus literature. And we started that. We realized that macrolide antibiotics are very effective in many of the sinus situations, but also specifically in CF and sarcoidosis, and they've been used routinely for a long time. currently there's a large study, obviously in the UK, carried on this, and hopefully we'll have some great results from this soon. Immunosuppression is mostly effective in severe sarcoid and GPA, but later on, only a few years ago, when anti-TNF and all the biologics appeared, realized that using these in these cases are also very significant and makes a significant difference in these patients. The big revolution that lately happened, maybe 4 or 5 years, we've been seeing it in the Royal Brompton Hospital, are the biologics. And chest physicians early on had the nice approval to use things like omalizumab because of severe allergic asthma that's not responding to anything. And we noticed, and many noticed, that polyps do respond, and some literature show this as well. So we're very delighted to see these patients responding, but not all of them as well. And then mupirizumab is also effective in eosinophilic asthma and polyps, and a study was carried over by my colleague Guy Scally in the Brompton showing this as well. And more recently, there's something that is very specific polyps is dupilumab. So dupilumab was studied on thousands of patients, showing a very good effect on nasal polyps specifically, because anti-IL-5 and anti-IL-13, 4 and 13, sorry. But sadly, has not been approved by NICE recently because it's probably the expense because of the commonicity of nasal polyps. But I would say that we still managed to get it for some patients who failed all other treatments. So that's probably something that will really have a very great effect for nasal polyps in the near future. And cystic fibrosis, something almost like a miracle in some patients, but not all of them, is the CFTR modulators, which have changed the management of these patients a lot. And we'll see that these 4 of them here, elicaftor, ivacaftor, and lumacaftor, and tizacaftor as well, or a combination of 2 of them or 3 of them, like Trikafta, they have made a huge difference to cystic eyes. Speak to many of the cystic fibrosis patients and find that the sinus disease has been cured in some of them. Some of them had major operations before, but now they don't have any symptoms. But interestingly, we noticed something that's probably something new, that Trikafta can be associated with initial worsening of the sinus symptoms and then gets better later on. So what about surgery? We're still surgeons and we like surgery. Surgery is often required, but in patients with sinus dry because the polyps that don't respond. And in CF, just to help drain this infection or the polyps, but very infrequently in PCDs and really rarely in sarcoid and GPA. GPA only for reconstruction of the nose if it's destroyed by the disease later on when patients are in remission. So these are some examples that we, things that we did that we did not find in literature before, and we published them here. We found a small number of patients get a thickening of the nasal bones. We injected local long-acting steroids. It worked for a year or 2. It's improved, but not perfect, but it did something, despite that the patient being in systemic treatment. Only thing that worked was the local injections. But this is the effect of infliximab. We see that severe skin inflammation from sarcoid, how it improves so much by using infliximab. And then surgery for GPA. We will see these really damaged nose. This is a classical picture we see because the cartilage have gone. You get this appearance of inverted V, drooping of the nose, of the lower 2/3 of the nose inwards, and absorption here. And all you have to do is to reconstruct this, but you can't reconstruct when the patient is in remission. If they still have the disease, they'll get inflammation of the cartilage you put and so on. So we tend to reconstruct that with rib cartilage, or sometimes with simpler things like what we call diced cartilage, if the skin is loose and can allow that. That was done as a simple operation, just like a pocket with diced cartilage, put in permacore, which is the porcine derms. And that can make a big effect on the appearance of this gentleman. One interesting thing that we studied, and Guri was studying that study with us as well, that we met Professor Praveen Anand, who's interested in neurological conditions. And interestingly, I've always had this idea that there's some neurological problems in the nose. And some years ago, we looked at this and we took biopsies from the nose and studied the presence of various nerve receptors and neurological receptors in the nose in contrast to controls. And we'll find abundant of these in patients with rhinitis, and specifically non-allergic rhinitis and some allergic rhinitis. And this really explains a lot about non-allergic rhinitis. It tells us that there are sensory nerves that play a role in rhinitis, but also maybe that non-allergic rhinitis mainly do this. And I think it is true for that. Nasal hyperactivity, I prefer to call it, to be honest. So we just need to create some medical agent to treat non-allergic rhinitis. And someday we'll be able to do this when we work on more studies on this aspect. So that's for my medical part. Then my surgical part is with neurosurgery, ophthalmology, and plastics. I'm going to talk about this one by one. So early on, again, I had the navigation system, and there were talks about doing things beyond the sinuses. And we needed to do this. I mean, we wanted to do this because there are the prospect that you do major surgery without incision, without craniotomy, and so on. CSF leak repair was already established. We started doing this early on, but the other things. So I joined Nigel Mendoza early on in 2003, and I'm sure he says, and I think so, that we were the first to do joint endoscopic surgery in the UK. Started early on together, and Ramesh Nair joined us later at 2003, long time ago now. Something interesting I learned from this. I don't know if many of you, I saw that slide in my lectures before, but I love this paper, published many years ago, about surgeons who swear. Is it a myth or is it a fact? And that was a really nicely designed study that showed ear, nose, and throat surgeon didn't swear that much at all during operating. Orthopedics were a bit bad. Urology, not too bad. General surgery, a bit. Gynecology. But I think neurosurgery is about here. Sorry about that, Nigel. But it's fun. So we're doing that joint skull-based surgery together. And we started by doing pituitary surgery, but we discovered we can do other things like meningiomas, refractive neuroblastomas, clival tumors, and obviously CSF leaks that we were already doing, and more. So we worked together as four-hand surgeons without having incision, going through the nostrils. And that was one of the first pituitaries that we recorded, I think. And we're both very happy with the results. And we could see there's an improvement on the results compared to the standard techniques. And this is really becoming, or is the standard technique for endoscopic pituitary surgery now, in contrast to the previous techniques. We did other things. This is, for example, a refractive neuroblastoma that traditionally would be done through a craniofacial resection. And here, me just on my own, drilling into the skull base just beyond the frontal sinus here, exposing that tumor, removing it through the nose, and then here's the frontal lobe and the dura. It's open here, but you can see the tumor has been removed. And then we'll just repair that endoscopically with fascia lata, cartilage, and some mucosa, sparing that patient major surgery and staying in the hospital for a very long time. So that was a revolution at the time as well. I don't do this surgery regularly, but I'm very pleased that my colleagues, Will Grant, and our latest colleagues, Kath Rennie, and the latest Mark Ferguson, continue to do this surgery every week with a large number of cases, which is great for our department. I have great interest in endoscopic repair of CSF leak from the start, and I grew that interest and did a lot of research in it. We started having referrals for this from the beginning, and some of them neurosurgical operations, which you can expect, and some of them from trauma, like road traffic accidents, like you can see this chunk here, small number from endoscopic sinus surgery, and some from trauma as a sort. But look at this large one, spontaneous leaks. That really interested me. Patients with a spontaneous leak, it's a very unusual condition. This is my patient. He's having this watery discharge coming through his nose continuously. Has never had an injury, nothing. Just has CSF leak with a great risk of meningitis. It's not a common condition, but it is an important and significant condition. I developed an interest in this from the beginning, and we did some research on it. They are implicated, like benign intracranial hypertension implicated in them, but we don't always find it. But we do find that the majority, 85% are overweight, above 30 BMI, and it's much common in women as well. 75% of my patients in my groups that we published were women. And interestingly, the anatomy also helps. If you have highly pneumatized sphenoid and frontal sinus that I found in some of my patients as well, you can have it's common in these patients. Plus, the problem is when surgeons started repairing them in the beginning, the recurrence rate was so high, over 20%, improved gradually, still not 100%. It's never been 100%. In the literature worldwide, it's just around 90% because of the other factors like benign intracranial hypertension. And you see amazing things like this patient here present with nasal obstruction because the brain is in the right nose. Coming through this narrow stalk from the sphenoid, all this is brain and meninges filling the right nostril here, some fluid around it, so the patient is completely blocked. And then you come out from the right nostril, you go in the left nostril, you go right back in the nasopharynx, you find a bit of brain as well. And there's nowhere for that patient to breathe, so it's blocked. How did this happen through this narrow stalk? It's because of pressure. The patient has intracranial hypertension. So it did that. And that, when the radiologist looked at it, said this needs major surgery. But when you look at it, it's a tiny thing you have to remove, and all this is out. How about removing brain? Obviously, this brain is non-functional because it's in the nose. And so that was not a difficult surgery to remove this and close it with 3 layers. and she never had the recurrence. So that's how I came up with a 3-layer anatomic repair, because I thought you have to replace tissue for tissue. So I've always done that, and actually from 2004, and this avoided recurrences. I had 1 recurrence since then. For the dura, we used fasciolata because it's very strong. For the bone, I used cartilage from the septum or bone pate if it's in the sphenoid. And for mucosa, I use mucosa, free mucosa from the turbinate. It's an example of a frontal sinus encephalocele here in that patient with a defect. Again, why? Never had trauma, spontaneous, and doesn't have benign intracranial hypertension. And that was repaired through the nose, just a standard endoscopic approach without having to drill the whole of the sinus or anything, just drilling a bit of the frontal beak to expose this, and you can have a good view, and you can then, when you expose that encephalocele, you can see the CSF leak now. I've removed the encephalocele and diathermed it, and here is the hole. Use the fasciolata to plug that hole because it is strong, and then after that, you can glue it with tissue glue and put some cartilage over. That's cartilage from the septum. So that's my standard thing. I've always used 3 layers, and then I put some mucosa. Here's the glue coming in, and then I put some mucosa, free mucosa from the turbinate, and that's give us a very good success rate. But obviously, this is the surgery. Some packing in the end, some absorbent packing at the end of that surgery we put, which obviously these patients can stay in the hospital overnight and you can go home 2nd day or 3rd day. We described other things. We still managed to do a lot of these things endoscopically. A patient will have large frontal sinuses, not too large. You can reach them by doing endoscopic lophrobe, which we describe as well, and we use that technique for a good number of patients. This is fluorescein to show that where the leak is coming from spontaneously. That's surgery. It's important. That's what we discover as well. It's the adjunctive treatment because they still have benign intracranial hypertension. They're still overweight. So we need to do something about this as well. So surgery in itself is not sufficient because sometimes these patients will recur and in a different place, different site, different sinus. That's why we always work with neurology to assess them for this. And if they have increased pressure, we put them in acetazolamide for a minimum of 3 months, 6 months, and we'll try to make them lose weight if they're overweight. I have referred patients to gastric bypass surgery, which we published before as well. And interestingly, just by having this, the leak stopped. The leak was coming through a very, very small defect and stopped after the patient losing weight. So the results, traumatic leaks, we had 100% successful rate, and the spontaneous 94% first time and 100% on the second attempt, which is still not 100%, but no surgery is 100%, but we keep improving it. Other thing I got interested in outside the nose, in the neurosurgical vicinities, is cholesterol granuloma. I was sitting in a meeting with my colleagues at Skull Base, and the otologists were talking about cholesterol granuloma because it was pressing on the nerve because of hearing loss here. And the approach was a lateral approach, which is fraught with problems because of the brain and so on. And I said to them, how about doing it from the sinus? And they were a bit surprised, and I thought, why don't I do a study? We looked here. I mean, this is a scan that, from the literature, show that the wall between the sphenoid is very thin. That's easy to open, but a lot of them have this thick bone. So I thought, let's just study that and just find a way to actually reach this here, this area, and drill it. So we used cadavers, and we used the navigation system to find the best site to open it into the petrous apex, and that navigation helped us, and we found it's really consistent. It was an area at the angle here between the posterior wall and the clivus, and near the carotid artery, on a vertical part here. And it was almost every time you drill there, you will find it. So that allowed us to do cases like this. This patient presented with pressure, headaches, and pressure on the 6th nerve with the lateral rectus palsy. So that was drilled through the nose, and here you can see I'm drilling into that hole. And this is the fluid that is being removed from cholesterol granuloma, pressing on that nerve. And imagine if you try to do a lateral skull base approach, it's much more major surgery. That was done endoscopically through the nose, and the patient went home in the morning. So that was the drainage through that one. So next one is ophthalmology. And I'm very delighted that I've worked with ophthalmology right from the start, because Ian Mackay had already been working with Jane Olver doing lacrimal surgery. And later on, Rajni Jain joined us, and I still work with Rajni. Jain has left the Imperial. And then later on, Vicky, I worked with her for a while, but not regularly now. And the latest addition is Ahmed, who is working with us regularly as well. Ophthalmology, the territory of ophthalmology is big for us. There's a lot of things we could do, and the commonest is lacrimal surgery for watery eyes, which we did regularly. But oval decompressions is a big thing that we do through the nose for thyroid eye disease, or for other things, and optic nerve decompression for traumas or tumors. But then we started doing tumor biopsies, tumor excisions, and foreign bodies. And the latest thing was transorbital neuroendoscopic surgery, which is becoming a big thing, and we have revived that recently. We started a few years ago, but we revived it now. I started doing DCRs with Jane right at the beginning, and in 2002 we adopted the technique of PJ Wermelt, who's also one of my mentors, describing using a drill, and improved the results so much of this surgery it became almost equivalent to the standard open surgery, and probably even better. So that's what we do nowadays, endoscopic surgery. Oral decompression can be done for severe things like eyesight-threatening cavernous sinus thrombosis in this child, but also more routinely for thyroid eye disease, and sometimes only because of dry eyes or just cosmetic that we still do routinely through the nose. So there's no scar. The standard scar that was done in the standard practice is not done because it's all done through the nose, and very low complication rate is something that we do routinely. And this is just simple endoscopic decompression. And even here, it came after the technique has been well established and we're confident about it. We've done decompression for patients who don't have thyroid eye disease or anything else, just large eyes because of myopia, just pure cosmetic operation, because the complication rate is so low. Things like optic nerve decompression is something that less common, but it's really an important surgery to be done by rhinologists, and you can save the eyesight. Somebody like this gentleman who's attacked and has a hematoma and fracture of the optic canal here. I did an optic nerve decompression within a couple of hours of that trauma, and he regained his eyesight. He would have lost his eyesight if he left it for a few more hours. So that's an important surgery to do. And again, you do it through the sphenoid. You just open the sphenoid and see the optic canal. He drilled it very gently in that patient with a very large sphenoid wound meningioma, pressing the optic nerve, exposing the optic nerve here, and then just very gently open the sheath to drill a bit of CSF, release that pressure that tumor is causing until that tumor is removed. So things like this are very useful, and we've worked with that right from the beginning, and we continue to do. Tumors of the orbit. Well, there was nothing in the literature about this, and we started working in this, published a few things on this, and we started by biopsying the orbit early on, presenting with some things that can reach through the nose. We worked on this, and then we worked on removing tumors, and then later on combined external endoscopic approaches to tumors within the orbit, beyond the orbit, which is the Tones approach as well. So we did that many years ago. We started and continued until Jane left, but things restarted again now. So something like this, like tumor in the involve this medial rectus here, and it's very near the nose, so it's very simple actually to go endonasally, expose that, and take a biopsy from here, and it was proven to be Hodgkin lymphoma, and so on. Many tumors like this we did. Well, that something like this neuroma, it's in the superior medial orbit. It's very near the nose. That's accessible for us through the nose, and we remove that through the nose. Something like this large osteoma, it's in the nose, it's ethmoid, but it's extended within the orbit, pressing on the optic nerve here and the medial rectus, and that again was removed endoscopically. Very thick, as you could see with these osteomas, and broke my drill here, but it was removed safely, and patient eyesight was normal. It's just a blood after the surgery. Joint surgery like this cavernous meningioma, incision, external incision, but put the scope through and work with the ophthalmologist to excise these tumors. And just a matter of interest, this gentleman, poor man, was attacked with a pen. For whatever reason, this pen went through here, and then he was left with this part at the end of the ball pen inside the orbit, sitting there right at the top here, near the optic nerve. And through that, if you try to open this through the orbit, external approach is hard and is fraught with complications. So we did that endoscopically using navigation and similar things we did, but that was the more interesting one because it was very posterior. And this is the medial rectus muscle that was exposed, obviously with the help of the navigation system that really helped us to find where it is, and to be able actually to access it gently and just manipulate it around that medial rectus and find that bit of pen, which is a bit of ink that you don't really want to leave in that orbit because it's going to cause problems sooner or later. Here it is. So a lot of things to explore with ophthalmology, and we really continue and we enjoy. Then finally, the other group of surgeon I worked with are plastics more than max facts and dermatology, and we have revived work with plastic recently. Over the years, I've worked not regularly with plastics, with plastic surgeons, do some joint surgery on and off, but then lately we're doing more now. And I'm delighted now that Simon Wood I worked with for years, Simon Wood, Naveed Jalali, and Jonathan Dunn have created the new facial reconstruction unit. When we treat, we have MDTs and we see all the patient facial reconstruction. My area is the nose, obviously, and we work on these together to get better outcome. And that is only a recent thing. Over the years, I've been doing nasal reconstructions, and I'll just give a couple of examples. This patient here who has damage on the skin, he was a smoker, he had surgery, rhinoplasty, and then he had necrosis here, and he lost his skin. He had a bad scar. So this is a nasolabial flap, just reconstructing this. Looks horrible in the beginning, but later on looks nice. And things like this can be accessible to us as ENT and plastics. We can work with plastics, we learn from them, we learn from us, and it's a great joint work. Something I want to show, and I'm showing my lectures more and more nowadays. This is the horrible CT scan, or it's a horrible MRI. You can see this is empty, there's nothing in here. This is the patient who used cocaine for a long time. Cocaine itself does not cause that. It's the levimazole that is added to it. That levimazole is implicated in this, and this patient inside the nose is being destroyed. There's nothing. It's a granuloma. It's completely gone. I'm seeing more and more patients of this. This is that molecule of levimazole, which is an anti-parasite drug, which was banned by the FDA years ago because of complications. But somehow the drug dealers found it and realized that it actually potentiates absorption of cocaine topically. So if you add it to cocaine, you put it in the nose, it absorbs slower, so you get more effect. So in the 2000s, early on, so only 20 years ago, they started adding it. And this is a map from that study on levimazole showing where it's added. South America here, a lot of North America, some in Africa and so on, and Asia. And obviously it's added there, but it's all coming here, I'm telling you, because look at that. The Thames is awash with cocaine. This is the study from King's that shows there's a lot of cocaine in the Thames water. And I'm seeing a lot of patients with damage in the nose because of this, and it's a levimazole. And even the eels in the water have been affected by the cocaine. They are all high now. So it is everywhere. And I'll show you an example. This is a gentleman who used it not very long time. I'm sure it has a levimazole in it. You can see the damage in the skin and the cartilage. You lost the skin here, that's completely collapsed. The skin becomes very unhealthy. He loses the cartilage, and they're very, very difficult to treat. So these are the kind of patients we have in our reconstruction MDT. So this patient had major surgery, again, with reconstruction with cartilage from the rib up here, of the dorsum, lateral ala, the columella, but also a nasolabial flap, like I just showed another man, to this columella. And you can see they're very nice. You can't see the scar that much here. But hopefully, you know, this will hold if he doesn't use the cocaine again, because a lot of these patients use it again. But it's really a damaging thing. Then, just toward the final part of my talk is the Septuarinoplasty. I was lucky to be trained by Ian Mackay and spend time with Tony Bull and my fellowship in Holland with Gilbert North Trinity and Harry Bauch, and I became very interested in Septuarinoplasty. In the NHS, obviously, we do functional Septuarinoplasty, which is an important part of the greater part of our surgery. And we have recently just done this paper on the evidence base of benefits of functional Septuarinoplasty, which is going to be published very soon, and just shows how the nasal airway is very important. And I'm showing here two examples of very badly deviated noses. This is trauma. This is a young patient, but she probably had a trauma as a child, but she doesn't remember, but she's young. It must be trauma. These are very difficult noses that you need to correct because these patients can't breathe apart from the appearance as well. And for these surgeries, you have to do major operation. So that's why mini rhinoplasty and septoplasty are technically challenging, like these ones. So some years, I discovered a friend of mine in Austria was using a PDS plate for nasal surgery, and we developed on this and worked with the American colleagues to get approval of FDA to use this in reconstruction. It's just a scaffolding. It's an absorbable material to help you to reconstruct the very damaged, irregular structure of the cartilage. We published a lot of data in this, and I used it basically for severe septal deviation, severe middle third deviation, severe congenital deviation in the form of extracorporeal septuarinoplasty. You remove the whole thing, fix it, and put it back. So it's a small number of patients, cases that fit these criteria, but they cannot be treated otherwise. It's very hard to correct them otherwise. There are other techniques, but this is probably the easiest one. You take the whole septum out and you reconstruct it by dividing all the fracture line on that PDS plate and put it back on. I published data on at least 10 papers on this, and I still use it in this kind of patients. And here is that patient gets straightness like this with improved nasal breathing, and also the other patient that you can see, and that's the same technique. Lately, I've been talking about this anterior septal deviation. For many years, people talked about skeptoplasty. Septoplasty, that is skeptical skeptoplasty, because there's a lot of recurrence. And I believe very well that the reason for this is that it's not very well understood that the major part of the problem is that anterior part of the septum, and it's very difficult to correct. And that's why I'm working on this now. The anterior septal deviation, almost invariably, it's a functional problems, and it's difficult to actually correct. Quite often you have to open the nose, open approach to actually get to that. And it's really, I've not been taught, at least in my generation, not been taught to everybody unless you work with a rhinologist. It's not a common practice. And that's why there's a failure on septoplasty. So I like to modify classification, or existing classification for this, but I modify the classification and think of a systematic way to prepare them into caudal in the bottom here, dorsal or combined, and then you think about ways of repairing them. Because obviously this is the subject of a different lecture, but just simply I always have to fix them back to the nasal spine with strong sutures after making a hole like this. We'll publish that. Sometimes it's really bad. This is the needle when I'm fixing them to the spine with that PDS suture. So the needle creates a hole in the nasal spine. I'm using a large septal extension graft from the rib to reconstruct that caudal septal cartilage, which was very, very deviated and caused severe obstruction. Stitching back in to the nasal spine using that PDS suture, sorry, and fixing it then to the upper lateral cartilages to create a fixed straight structure which will open that nasal airway. So you can see this is just a functional surgery. The patient cannot breathe, but really there's probably no other way of correcting it. Anterior septoplasty. I'm not saying all the septums have to be like this, but this is quite a severe one. And we have to understand the implication of these anterior septal deviations in the nasal airway. So that's the final suture into the upper lateral cartilage just for fixation, and then you get that fixed structure, which is very strong. That leads us to the nasal valve, and that's why these anterior septal deviation narrow the area. The valve between the upper lateral and the septum and terminate here is only 10 to 15 degrees. If it is too narrow, it's blocked. I have thought about this a lot, and anterior septal reconstruction is important for repairing this. Sometimes you can work on the valve with simpler surgery, which we described a couple of times, Zydplasty and so on, and that can help. And we've shown a lot of data with above 95% improvement on some simple surgeries like Zydplasty of the internal valve. Finally, that leads us to aesthetic rhinoplasty, which is one of my favorite things. If you do Septuarinoplasty, if you're an ENT surgeon, you find yourself, you get trained in this. If you're a rhinologist, you get trained in this. In the UK, rhinologists do rhinoplasty. In the States, rhinologists are different from rhinoplasty surgeons or facial plastic surgeons. But we combine them here. So from early on, I started doing aesthetic rhinoplasty, and it's a very rewarding surgery. It's great joy. The majority of the time, patients are very happy, and it's great. As long as you understand the patient, because it's not just about your surgical skill. The psyche of the rhinoplasty patient is very important. And remember that any surgery can be unpredictable, more so with rhinoplasty, perhaps because in the face, perhaps because in apparent complex anatomy, there's cartilage, there's bone, there's mucosa, there's skin. So there is higher revision rate in rhinoplasty than any other surgery in the world, probably. So you have to be aware of this. And from early on, this is the father of rhinoplasty, Joseph, who said psychological aspect of aesthetic surgery is as important as its physical success. So he knew that, and that's why it's important to remember this. You will get patients with unusual demands or desires on his nose. You just worry about this desire a bit, and you worry a bit more when somebody with this nose wants this nose. So then, would you do this? Can you do it? Probably not technically. So you have to be aware that this patient is really have higher expectation that can happen in real life. So that's not something that you have to take lightly. So that's why people describe body dysmorphic disorder, which became more common in the media now. We published some papers on it as well. When patients think there's something wrong with them, but there's nothing wrong. But that's not the whole story. That's why I really thought it's very important to work with a psychologist, and very lucky to have found Deborah, who started us a year ago and who has main interest in rhinology and rhinoplasty, to look into these patients. When we work in publishing various papers, we have one in publication already, but there's a lot of patients who have things that can treat, and then they present with a condition for rhinoplasty because they're projecting something else, such as depression, There's appearance-related anxieties, low self-esteem, and then adverse childhood events, which is very important. Things like this can be explored by psychologists and looked into and help the patient to get through them, to have the surgery or not to have the surgery. So I think working with a psychologist is really important if you're doing aesthetic rhinoplasty or aesthetic surgery in general. When you do the right thing, you get patient already happy, like this patient with a hump and a white tip, give them the nose and they're really ecstatic and they make your day. And that's really nicely the majority of the patients are like this. When you make the right selection, or this another patient, the standard endonasal techniques that are used in the majority of the patient to narrow that tip, remove the hump, and improve the profile, and so on, which is a big part of my practice as well. So I hope I've shown you the voyage that I've been through, exploring all the areas that into the nose and outside the nose and exploring further. I think there's still a lot more to do. And if I think about the future, I'm sure there are more than I'm going to say to you now, but I really think artificial intelligence will be implicated a lot in our practice, reading the scans and reading pathology, slides and so on. That would be just artificial intelligence and will make a difference. And Imperial is working a lot on this already. That's one thing for investigation. Advanced in medical treatment, as I showed you, is happening already, and I think will be more and more of this coming through. I'm working jointly with Professor P.J. Wamelt and Sarah Berger in Melbourne on eradicating some resistant bacteria, and this is something that is being done as well, and we're working on research on this, and hopefully we'll be able to do this. And I think there's a role for stem cell research in various parts of the nose, but particularly in neurological tissue like olfactory problems. And this may be one of the revolutionary things that can happen in the future. And people nowadays more and more realizing how important olfactory problems are, and more research is being done on them. 3 digital cameras in surgery are still already there, but it's probably going to be a commonplace more and more in the future, as well as robotics, which are commonplace in other surgeries, but not within our field. They may do as well. Here is us doing that robotic surgery with these sunglasses. I know that next generation, we're not going to have these sunglasses. It's a bit dark like this, but it did work, but I'm sure we're going to be better and improve. Like everything else we saw in my only 20 years or less in rhinology, I've seen so many developments, and I'm sure this is going to develop much more soon as well. So just to show, this is, you can see that some of my colleagues here, but I just want to show you, this is a nice thing that in my first day as a professor, this is from the left, Valerie from our clinic, Catherine, my colleague, consultant rhinologist, Mark Ferguson, consultant rhinologist, Jen McGill, specialist registrar, Lizzie, our specialist rhinology nurse, our senior fellow. And this is just our team. I just want to thank my team, my friends, for all the time we spend together, all the support, all the fun we have developing things and working together. This is our team in rhinology: Will Grant, Catherine, me, Mark Ferguson, the consultants, my current fellow Shirini, the SPRs, Jen, Miguel, and Nora, and our rhinology clinical nurse specialist, Lizzie, and our psychologist, Deborah, rhinology psychologist. I never show a lecture without showing my travel club. Guys, hi. Because I miss them, we have been traveling for 16 years, and we had to cancel our travel club for the first time ever this year. I hope it's not going to happen again. These are my colleagues there, so hi guys. I do miss them. I haven't seen them for over a year now. Finally, she didn't want me to put her picture. This is my wife, Hala. I just want to say that I wouldn't have done anything, no success, nothing, without having her beside me. I know that I'm a bit of a pain sometimes, but I work so much sometimes, and I'm so demanding, but it was important. Sorry about this. I showed you a picture. So thanks again, and this concludes my lecture, and I'm open for questions.
Sorry, Hesham, tremendous lecture. Sorry, I was clapping in silence. Well done.
Thank you.
And I know you've left out many topics that you are a pioneer in, and hopefully we get to hear about those in the future. But well done, thank you. Now I have some questions from the audience, and I'm going to start with one that interests me, and it was asked by a member of the audience from Turkey. Hypothetical. You have the world's most famous female opera singer. She's got an overly large nose, but no other nasal symptoms. She's come to you because you're the man.
Right. Yes. So she wants to make her nose smaller. She's worried about her voice. Is that
Exactly.
right?
Resonance. Yes.
That is always an interesting question. I have had patients like this. If you make the nose tiny and you give the nasal obstruction, you give the nasal voice and you affect the resonance. So you have to have a balance. You can do a rhinoplasty. I have done on singers, as long as you have a balance. You have to explain to that patient, I can make your nose smaller, but not too small. So just make sure that the valve is open enough, nasal airway is open enough. If you narrow the nasal airway too much, you will affect the voice because of the voice becoming nasal, but also because of resonance.
So the answer is go to the right person.
Yeah.
Go to a rhinologist. Get an opinion. Okay, you talked a bit about deviated septums. Now, this is an operation we think is a simple, straightforward operation. To my mind, this is one of the most challenging operations in which to get long-term good results. Yeah? It may look good as you close up, but sometime later it looks like you've never done anything. Is this a lost cause?
I don't think so. I think it's, as any operation, it is a hard operation. As any operation, you can never have 100% success. I can improve that success by understanding the anterior deviations because they are the reason for failures. The standard way of doing septoplasty was to remove some spur or deviated bony section and thinking that the rest of the septum would straighten. But a lot of them are C-shaped, they have natural curve in them, or they have a natural angle with a fracture line. This is not going to go out of the way, especially if it's right in the front, narrowing the valve. And here is where you have to do that bigger operation and to be able to actually go and reconstruct the area and make it straight and adjust it with the nasal valve. And that's where training comes and understanding that anatomy. And I think that is the reason that people call it septoplasty, because of failures of understanding the anterior deviations. Yeah,
okay, so thank you. So a couple of questions in two parts. The first one from Tim Wolford is, with COVID and the long waits in the NHS, do you see rhinoplasty, septorhinoplasty, still going on in 5 years or so in the NHS?
The short answer is yes. And the reason is because the functional rhinoplasties are important. And we've shown in our study that's not going to be published, that's not going to publish yet, how the nasal breathing affects a lot of the system in the body in any way. So this is functional rhinoplasty. When more and more data is showing from the current study on septoplasty versus control, which is done nationally, will show the importance of improving the nasal airway. And that's where functional septorhinoplasty comes, because sometimes you cannot straighten the septum without doing a full septorhinoplasty. So I think this functional septorhinoplasty, as we do in NHS, is not going to go away. But I think it's going to probably centralize in some centers that do this kind of surgery. This is what I feel. Yeah.
So the part B of that question then is, where do you see rhinoplasty practice in 20 years?
I'll see rhinoplasty practice in general growing, because this is what we've been seeing. And there's a lot of data that BAPS published, for example, showing the desire for aesthetic rhinoplasty is increasing all the time. It's probably the media, the affected peers, the friends, the social media and all this stuff. It's becoming more and more popular. But I think rhinoplasty will continue. ENT do rhinoplasty, plastics do it, maxillofacial do it. I don't think it will change. By nature of training and so on, ENT get trained more in doing nasal surgery. If things become a bit more centralized, so probably you have to go to certain centers to learn it. But I think rhinoplasty is going to increase. It's not going to get less. Definitely.
And someone's actually asked, has there been more demand for septorhinoplasties during the COVID lockdown? I don't know what the relevance is, but
interesting. Yes, and I'll tell you what the relevance is. Yeah. Interestingly, I've always saying that during the lockdown, we get a lot of calls and patients. Can I have my rhinoplasty now because I'm at home and I'm not going to work, so I can recover? That is the reason. And even in the middle of COVID, the pandemic, and say no, we're not operating because there's a risk. We didn't know then what's the risk and so on. But people were always contacting. So I find the demand was higher, definitely. I mean, it's just my subjective feeling.
All right. Well, look, one other COVID-related questions. We're all familiar that one of the presenting symptoms of COVID infection, loss of smell. and taste. But someone's asked that they've seen many reports of dry, painful nostrils, altered nasal secretions that have the consistency of glue. And they want to know, what is that about? Is that COVID, or is it superimposed some other infection? What is going on?
It's probably superimposed infection. By the nature of COVID, we know it's like the nerve. It's a neurophilic virus, in some patients at least, which just goes to the factor A and just damages. And even the report that it may actually cause other intracranial things. Dryness and crusting in the nose will be either because of dry secretion, infection, and so on, because of ciliary dysfunction or something similar, which can happen in any infection. I cannot think that this is specific to COVID, to be honest.
Okay.
I think so.
All right. Well, look, Hesham, I'm going to have to call it there because we've got our next speaker. Thank you very much again. So our next speaker is Professor Stephen Durham, who's Professor of Allergy and Respiratory Medicine at Imperial College and at the Royal Brompton Hospital. And you've mentioned him as working with you in the nose clinic. He is going to give the vote of thanks. So welcome, Stephen.
Good evening, everybody, and thank you very much, Guri. I just want to say, Hesham, on behalf of everybody present, to thank you for a really brilliant and entertaining lecture. You really have carried forward the flag of rhinology and brought tremendous prestige to Imperial College London and to Charing Cross Hospital and to the Royal Brompton Hospital. And certainly on behalf of my colleagues here at the Brompton, we are totally indebted to your commitment to our patients with chest disease, many of whom have nasal disease. And that's hence the birth of the combined nose clinic some 20, 30 years ago now. What people haven't mentioned is that you're actually a brilliant clinician who just sees the wood through the trees. You have such a lovely, easy personality, and you really do put our patients at ease. And that is a really very special skill that you have. Now, we know that you have achieved international recognition as a surgeon, as a teacher, and as we've heard today, through these phenomenal and brilliant innovations that you brought to the field. You're also ex-president of the RSM Laryngology and Rhinology section, and the British and European Academy of Facial and Plastic Surgery. You have over 130 peer-reviewed publications, greater than 30 chapters. Although I'm sure that what swayed the promotion panel at the Imperial was the fact that you were voted the UK's top rhinoplasty surgeon by Tatler magazine in 2019. So there's an achievement. But seriously, you're a brilliant teacher. At a personal level, your contribution to the MSc course in allergy, the rhinology section over the past 20 years has been phenomenal. And you've given over 1,000 lectures, more than 70 a year. Many of them this year, I'm sure, have been online. Just to have a personal reflection on the medical surgical nose clinic at the Brompton. As you mentioned, this was started in the 70s by our mentor, Ian Mackay. And indeed, Valerie Lund was one of her first senior registrars. And this was with Peter Cole. And I had the privilege of working with Ian from 1988 through to 2004, I think it was, when he retired. I don't think I've told you this, but in 2001, exactly to the week, 3 years before he retired, he said, "Stephen, I want you to know that I'm retiring from the NHS in 3 years' time," I think when he was 60. But I just want you to be reassured that I've got a wonderful successor for you, and you don't need to worry about that. And of course, he was absolutely right. And it really has been a delight, Hesham. I think, what we've learned working together is that a successful collaboration is actually about mutual gain. It's about complementary skills. But above all, it's about mutual trust. And for us, certainly, I think what's been a real bonus has been friendship. And we've had all of these things in spades. So thank you for your contribution to the Brompton. And thanks for giving us such insight today about the broad practice that you've performed over the past 20 years. And I'd also like to take this opportunity just to thank the brilliant 30-odd ENT registrars that we've shared over the last 20 years. As you know, the acid test for them when they come to the Brompton for their 6 or 12-month rotation is whether they can successfully navigate an honorary clinical contract at the Brompton. After that, there's no problem. But they've worked tirelessly alongside our own registrars to bring innovation and humour, and constantly of an exceptional standard under your guidance. So thank you for that. And it's a collaboration that I'm sure that will long continue. And also I should mention thanks for the ITU colleagues at the Brompton, who are totally indebted to you and your registrars for the support that you provide for them on call and also from the nose clinic. I'm truly delighted that your wife, Hala, is here, Hesham. And I just want to finish by, on behalf of all of us, sincerely congratulating you both on your professorship and for such an enjoyable inaugural lecture, and also for providing us with some insight into the future of rhinology. And we look forward to that very much indeed. So thank you very much. And again, congratulations, Hesham.
Thank you so much for your kind words. Thank you. Really nice. Thank you.